I'm Dr. Philippa Pavia, board-certified veterinary surgeon, and today we'll be talking about wound care and healing.
This show is sponsored by Cruise Manuka Honey, your first choice for moist wound care. Visit cruise.com for more information.
Like so many of you out there watching right now, I started my career cleaning kennels. From there, I went to college, got an English literature degree, took a little detour. Then I went to veterinary school at the University of Pennsylvania and completed my training, my internship and my residency at the Animal Medical Center in New York City. Since then, I've been practicing as a board-certified veterinary surgeon for the past 5 years. So, before you start tackling any wounds, you have to understand a little bit about the anatomy of normal skin, specifically blood supply. We're very lucky dealing with dogs and cats as compared to people because they have a pretty robust blood supply. Of course, we think about those large blood vessels that you might want to use for a flap, but in most wounds, all you really need to know about is the local blood supply, and that's a subdermal plexus. As we always say, cats are not small dogs, and that definitely counts for wound healing. They have fewer of these little blood vessels that perforate their skin, and it can take longer for their skin to heal as well. So we have to keep that in mind when we're treating wounds in cats. Before you start treating a wound, it's important to understand what type of wound it is, because not every wound can be treated the same way. There's lots of different methods of classification. One of them is timing. Is this a wound that just happened, or is this a wound that might have happened a few days ago when the cat got out of the house? These are all really important factors. Is this a clean wound? Is it a clean contaminated wound? So one that's not quite clean, but you can easily lavage it and get it to a clean level. Is it a contaminated wound where you can see that there's gravel or some sort of obvious dirt in there? Or is it a dirty or infected wound? Maybe a surgical wound that got infected that you're worried might have a multiple drug-resistant bacteria in it. Is it something that happened a week ago? So these are all really important factors to take into account before you start treating that wound. It's also important to think about what the cause of the wound was, because that can affect healing and can affect treatment. We can think about these different types in different categories. There's an abrasion where the forces are going in parallel to the skin. There's a laceration where it's a straight cut and those forces are going perpendicular to the skin. Then there's a shearing force where there's a twisting or a motion against the skin, and that can cause the really severe wounds like degloving, where a large portion of the soft tissues are removed from the distal limb. Other types of wounds are categories in and of themselves, including bite wounds and burns. So bite wounds are probably one of the most common type of wounds that we encounter as veterinarians, and this could be an entire lecture in and of itself. Bite wounds can sometimes be much worse than they initially appear, and that's something that you'll definitely want to communicate to an owner. They can be the tip of the iceberg, because as the tooth punctures, you don't see the vascular injury that's happening beneath the surface. It can also be delayed because that vascular injury can lead to tissue damage even days after the initial injury. What I like to tell owners is just that this may be the tip of the iceberg and that a bite wound may take days to truly declare itself, and we might need to be working with them for a while. Burns are something we see less commonly, but they can be equally concerning and even more complicated in terms of their treatment. Particularly, burns can also have massive systemic effects. There can be tissue fluid loss, plasma loss, hypoalbuminemia, anemia, and so we really got to get our friends in our emergency and critical care services together to help us with burns. So one of the first things you're going to want to do when you have a wound is clean it. First, of course, take a culture if you think you're going to need a culture for antibiotics. Antibiotics are usually indicated in wounds, but cultures, not always. We usually do a culture if it's an infected wound or a surgical wound, but for some wounds that have just come to you off the street, you won't necessarily have to do that. So, how do we clean these wounds? There's a lot of controversy about the right way to lavage. There's some pretty good research out there, however, and that suggests that what you should do is get 7 to 8 pounds per square inch, or PSI, of pressure behind your lavage in order to flush the bacteria out, but not flush them deeper into the tissues. How do you do that? There is a study that shows that you take a liter bag of saline or LRS. You don't want to use P-Light because that can burn. You place it in a line with an 18-gauge catheter and a pressure bag. So those are those pressure bags that you pump up to bolus fluids. You'll want to use that with your liter bag. And you pump that pressure up to 300 millimeters of mercury, and that will get you a consistent 7 to 8 psi. One of the topics of wound care that seems to lead to the most stress in doctors, particularly new doctors right out of school, are drains. When to place them, how to place them, and what to tell an owner about how to take care of them when you send the pet home. There are two types of drains that we use most commonly: passive suction drains, and those are your Penrose drains, and active suction drains, or your Jackson-Pratt type of drain. Commonly, with a Penrose drain, the question will be, how do I anchor it? Where do I place it? Important things about the Penrose drain are to anchor it at the exit site and at the proximal aspect, but do not make a hole proximally. We call that a through and through drain, and that can actually invite bacteria and infection into the wound. So, place your Penrose drain away from your incision. You don't want to suture over it and then have to try and get your Penrose drain out when you take your sutures out. Anchor it proximally, tunnel it separately, exit it through a separate stab incision, and then take a single skin suture and anchor that exit site for your Penrose drain. For your larger wounds, things that have a lot of dead space or maybe very contaminated, and you're really worried about the amount of exudate that's going to be produced, you'll want to use an active drain, like a Jackson-Pratt. Those are the ones with that balloon. We call it a grenade sometimes, as it kind of looks like that. And it creates a constant suction or vacuum, which pulls the fluid out of the wound bed. Those can be a little bit scary for owners to go home with, so I'd recommend that you have a template ready to send them home with that. They'll also want to make a little bit of a chart so you can know when that fluid production is abating and when you should take out your drain. The general rule of thumb for when to remove drains is about 5 days. If they're still needed after about 5 days, you might need to do something else with the wound if there's still that much fluid being produced. One of the most common questions that I get is, when should I place a drain? I joke that if you think you might need a drain, you should probably use one. But really, the place for a drain is in any wound that you're worried might have dead space. So in a wound where you can't tack those layers back down and you're worried about fluid building up between those layers and preventing healing. Again, think about blood supply. If there's space between the layers of tissue, that blood supply and that healing is not going to happen. Another place that you're going to want to place a drain is in a contaminated wound. You want an ability to get all of that contamination out with the wound fluid. You don't want it to be trapped inside. Like everything with surgery, bandages take a lot of practice. They also seem pretty simple, but they're definitely not. So things to think about are the different layers of a bandage. There's the primary contact layer. We'll go into a lot more detail about what you can put directly onto a wound. And then there's your secondary and tertiary layers that usually include cast padding, cling, and some vet wrap. Sometimes you'll want to put a splint on a bandage as well, because you may want to immobilize the wound. Other decisions you need to make are, what are the patient factors? Is this dog going to need an e-collar? Are they going to be bothering at their bandage? Other things like that. So the first and probably most important decision you're going to want to make with a wound is what you're putting on it. And that's the primary layer or the contact layer. You want to think about what stage of healing this wound is in. Is it a brand new wound with a lot of discharge? Is it a mid-stage wound with some granulation tissue, but the wound bed hasn't healed over yet? Or is it a wound that's starting to epithelialize? These are all really important and very different stages. One of the reasons why that's so important is you want to keep the wound moist. You do not want to allow a wound to get dry. That will inhibit all kinds of good things like angiogenesis and fibroplasia. Ways that you can maintain wound moisture without macerating a wound or allowing it to get too wet are these different contact layers. You also want to think about if there is infection or contamination, and that will drive your decision for the contact layer. There are different products which will keep moisture in, and there are other products which will bring moisture out. There are other products which will enhance granulation, and there are others that actually might impede granulation. Other products you may want to use in a contaminated wound or wound with a lot of discharge could be something like a sugar or honey. With honey, of course, you'll want to use a medical grade sterile Manuka honey. Those products are osmotic agents, so they will draw some of that swelling and edema out and help bring perfusion and oxygen to the wound surface. One of the products you'll read a lot about is honey. You can't just go to the store and get honey off the shelf. You'll want it to be medical grade, sterile Manuka honey. Honey has a bunch of incredibly unique properties that help with wound care. Number one, it has a different osmolarity, so it draws fluid out of a wound and decreases edema. It also has hydrogen peroxide in it, which is acidic. It brings the pH of a wound down and kills bacteria. In vivo and in vitro, it's been shown to kill some multiple drug-resistant bacteria as well, and then you don't have to worry about that resistance profile. Other things that we don't necessarily know everything about are the different phytochemicals in honey that we think do a lot to promote angiogenesis and wound repair. There are two other types of bandages or wound care devices that I think are pretty important. One you'll want to use almost every week. The other you might never use, but you should still know about when you're talking to your clients about it. One is the tie-over bandage. This is extremely useful for anatomical areas where traditional wrapped bandage isn't going to work. There's a lot of different ways you can do a tie-over bandage, but the basics are taking your sterile contact layer and some gauze, placing it in a wound, and then using something like umbilical tape with stay sutures around the circumference of the wound to hold that tie-over bandage in place. In even trickier areas like a limb proximally where you can't get a bandage to stay, or in a patient where those tie-over sutures, the stay sutures, are really bothering them, you can use a sticky wrap to keep your bandage in place. I've used these a lot and they're pretty versatile. There's one other type of wound care system, which you may not have at your disposal in your clinic, but you should know about it in case one of your clients asks about it. It's the VAC, better known as the Negative Pressure Wound Therapy System. It was developed for human military veterans and their wounds, but has been applied very, very successfully to our veterinary patients. What it does is it employs, just like the name says, a vacuum. And you apply a sterile foam to a large wound, usually a very effusive wound, where you'd have to be changing the bandages very, very frequently, and then a sticky dressing over top of it. And then a line goes to a vacuum machine that literally sucks that wound fluid out. It can be very, very rewarding and very successful in wounds that have had trouble healing in the past. Of course, a lot of wounds have dead or unhealthy tissue in them, and for that, you're going to have to perform debridement or debridement. There's a couple of different methods to do this. There's layered debridement, in which you slowly bring down the layers of abnormal tissue until you reach healthy bleeding tissue, and then there's en bloc debridement, when, if you can resect the entire abnormal wound bed and then suture things closed. Today we covered some basics like skin anatomy and blood supply in dogs and cats. Then we talked about bandages from the inside out, contact layers, as well as your secondary and tertiary layers. We also covered lavage and debridement of wounds, as well as drains, passive and active. We then covered some slightly out-of-the-box types of bandaging and wound care systems, like the tie-over and the back. If you have any questions, put them in the comments. And if you'd like to connect with me, you can find me on LinkedIn. Thank you so much for spending your time with me today.